Welcome to the Science for the Public lecture series. Science for the Public is an organization committed to bringing science information and issues to the general public. Visit our website for our program listings and blog. It's a great pleasure to welcome Robert Whitaker back. In May, he gave a wonderful presentation on the challenge of educating the public about the potential dangers of psychotropic drugs, especially for schizophrenia, bipolar disorder, anxiety, and depression. His focus in that talk was mainly on medications for adult patients. However, he also mentioned the increasing concern about psychotropic drugs for children. ADHD, childhood depression, and so forth. After the presentation, people asked if he would consider giving a talk on the rather extensive prescribing of psychotropic drugs for children. Mr. Whitaker kindly agreed, and I'm sure we're going to learn a lot this evening. But let me give you some background first. Robert Whitaker is a journalist and author of 4 books. His newest book, published this spring and already widely acclaimed, is Anatomy of an Epidemic: Magic Bullets, Psychiatric Drugs, and the Astonishing Rise of Mental Illness in America. An earlier book, Mad in America, was named one of the best science books in 2002 by Discover magazine. His other books cover very different topics in biography and history, and he's published fiction as well. Mr. Whitaker's background in medical science writing is extensive. He was a Knight Science Journalism Fellow at MIT, then Director of Publications at Harvard Medical School, and then a founder of a publishing company concerned with medicine. He's won several national awards, including a George Polk Award for Medical Writing and a National Association of Science Writers Award for Best Magazine Article. A series he co-wrote for the Boston Globe was named a finalist for the Pulitzer Prize in 1998. His recent book, Anatomy of an Epidemic, is an outstanding resource for educating the public about the long-term use of psychotropic medications, including such medications for children. It's a very great honor to have Robert Whitaker join us again.
Thank you all for coming tonight. It's a pleasure and an honor to be here. I think the topic tonight is a topic that is of big importance for our society. And what we're going to be talking about is the medicating of children with psychiatric drugs. And the reason it's so important is really there's never been a generation of children raised in the environment, in this sort of medical environment before in the United States or really in any other country. So this medicating, this diagnosing of children with psychiatric disorders and medicating them, it's a very new thing. And in some ways it's a very big experiment because we really don't know what's going to happen to these kids long term. And so one of the things we're going to do, what I'm going to try to do tonight, is review the evidence that we have in terms of whether this is a good thing or a bad thing or something to worry about. And the principle we're going to apply here is something called evidence-based medicine, and it's a very mainstream value. So if you go into any sort of medical talk, and if you even go to a psychiatric talk, they'll talk about, do we have evidence supporting our therapies? And this is in psychiatry, it might be in internal medicine, etc. So this is the way that mainstream medicine evaluates what it does. And one of the premises behind evidence-based medicine is that doctors can, in fact, be a bit deluded about their merits of therapies. That's one of the things that the history of medicine tells us. And that's why you have to do tests. You can't just use anecdotal evidence to say whether something works or not. So you want this scientific evidence to guide your therapies. And that's what we're going to go through here today. What's the science? What is science telling us about this grand experiment that we're doing? Now, the first thing we need to understand is, what do we know about the biology of these disorders, these childhood disorders, and what do the drugs do? Now, sometimes you'll hear the sense, we've all heard the sense that psychiatric disorders are caused by chemical imbalances in the brain, and the drugs fix those chemical imbalances. They bring this abnormal chemistry back into balance. So let's look at that real quickly and see if that's what we're doing with kids. The chemical imbalance theory, it actually arose obviously out of use of drugs in adults, but the way it arose really in the 60s is when they introduced new drugs, new antipsychotics and new antidepressants, when they came to understand how the drugs acted on the brain. So that hypothesis arises at that time. So for example, in the 1960s, they come to understand that thorazine and new antipsychotics, the way they work is they work by blocking dopamine receptors in the brain. So real quick science. The way neurons communicate, you have a presynaptic neuron, right, that puts out this chemical messenger, say dopamine. It enters the synaptic cleft, which is a small gap between this neuron and the receiving neuron, and then that chemical messenger binds with receptors on the receiving neuron, the postsynaptic neuron. Now what it was understood was that the antipsychotics worked by blocking the dopamine receptors. They blocked like 70% of them, and therefore they lowered dopaminergic activity. So the hypothesis was there, if these drugs are effective for schizophrenia, and if these drugs work by blocking dopamine activity, then perhaps schizophrenia is caused by too much dopamine activity in the brain. Okay? That's where the chemical imbalance theory of mental disorders arose. It didn't arise out of understanding what was happening in schizophrenia. It arose from understanding how the drug worked on the brain. So for example, depression. You've heard the low serotonin theory of depression. Same thing. They came to understand that, say, antidepressants block the normal reuptake of serotonin from that synaptic cleft. So we have serotonin released from a presynaptic neuron into this gap, and normally what happens is, in order and it binds with receptors, and then that message has to be terminated. And the way the message is terminated is in one of two ways. The serotonin is brought back up into the presynaptic neuron, or an enzyme comes along, degrades it into a metabolite, and that metabolite is carted away as waste. Okay? So what did they say? Prozac and the other drugs, they blocked the reuptake of serotonin. That means the serotonin was kept in that cleft longer than normal. It upped serotonergic activity. Therefore, they theorized that depression was caused by low serotonin. Okay? Again, the theory arose from understanding the drugs. Now, the way they then investigated that hypothesis is they basically looked at, and we're going to look at the schizophrenia hypothesis and the serotonin real quickly. They looked for those metabolites in the cerebrospinal fluid. So, for example, schizophrenia was hypothesized to be caused by too much dopamine activity. All right. So what they did is they looked for the levels of dopamine metabolites in the cerebrospinal fluid of people with schizophrenia, and what they found was they did not differ significantly from that of normal controls. Okay. So in fact, schizophrenia was not caused by overactive dopaminergic systems. In other words, that hypothesis fell by the wayside. It didn't pan out. Same thing with the low serotonin hypothesis. So they looked at the metabolite levels of serotonin in the cerebrospinal fluid in depressed patients, and they got this, and they were variable. Some people depressed sort of had the low end of the bell curve, some people had the high end, very variable levels. But when they compared those levels to the levels for, quote, normals, people who were not depressed, they were the same. Okay? So the serotonergic hypothesis really sort of fell apart in the early 80s. Same thing with the dopaminergic hypothesis. And just one quick quote. In 2005, this is from Kenneth Kendler, co-editor-in-chief of Psychological Medicine. "We have hunted for big, simple neurochemical explanations for psychiatric disorders, and we have not found them." Okay, so we just don't know what the biological causes of psychiatric disorders are. It remains unknown. And that's the same with, they also investigated this, say, with children with ADHD. Now, stimulants, what they do is they block the normal uptake of dopamine, so they keep dopamine an extra amount in that synaptic cleft. They're dopamine elevating drugs. So the hypothesis was that ADHD was caused by too little dopamine activity, always the opposite. They looked for that same thing, they didn't find it, and so, for example, you can say, and this is a panel by the NIMH in 1998, it concluded that after years of clinical research and experience with ADHD, our knowledge about the cause or causes of ADHD remain largely speculative. So adult disorders, do we know what the biological cause? No. Are they caused by some sort of known chemical imbalance? No. Same thing with the kids, the ADHD, we don't know what's wrong. All right? So that's the first thing. No known biological abnormality. That doesn't mean there might not be some biological underpinnings. It just means we don't know it. Now, the second thing that's important then, what do the drugs do then? If they're not fixing chemical imbalances, how do they act on the brain? And just for simplicity's sake, let's just look at Prozac, and that can serve as a model for basically all drugs, and we'll talk about this. So what does Prozac do? As I said, normally, you have a presynaptic neuron, it releases serotonin into the synaptic cleft, and then normally the serotonin, to shut off the message, is taken back up into that presynaptic neuron, most of it, right? What Prozac does is it blocks those channels, and so the serotonin remains in that gap longer than normal. So what does the brain do? The brain actually says, uh-oh, this is a problem. This brain is this extraordinary plastic organ, flexible organ. It likes to maintain these neurotransmitter pathways in sort of a normal fashion. So the minute you put, very quickly after you take a Prozac, your brain starts to compensate for that blockade of that reuptake process. And it compensates for two ways. So the drug is trying to keep serotonin in the synaptic cleft longer than normal. So what does the brain do? It actually starts putting out, the presynaptic neurons put out less serotonin for a while. Okay, it's doing the opposite. And in terms of the number of receptors on your postsynaptic neurons, they decrease in density. So because that serotonin is staying in the synaptic cleft longer than normal, the brain tries to compensate by going to sort of a low serotonergic state. Okay, you actually now, in reality, you're sort of creating a physiological imbalance or an abnormality. Now, I know this may sound odd, but in 1995, Stephen Hyman, who today is provost of Harvard University, and at the time was the NIMH, wrote a paper called A Paradigm for Understanding Psychotropic Drugs. And really, this is what I think should be communicated to the population because it's so different than the chemical imbalance model. What he writes in this paper, he says, and he's a neuroscientist by training, he says what psychotropic drugs do is they perturb neurotransmitter function in the brain. In response to this perturbation, the brain goes through compensatory adaptations trying to maintain its normal functioning. Of the sort I'm just talking about. Say the serotonergic receptors decrease in density. Just to give another example of that, remember the antipsychotics block dopamine activity? Well, what does the brain do? Since it's the drug tries to stop dopamine activity, the brain increases the number of dopamine receptors. Okay? It actually tries to become super sensitive to it. So it's always the opposite reaction, if that makes sense. Anyway, Stephen Hyman says these drugs perturb sort of normal function in the brain. In response to this, the brain undergoes these compensatory adaptations. And at the end of this adaptation process, the brain is operating, his words, in a manner that is both qualitatively and quantitatively different than normal. So I think the important thing here is as we move to children is because you often hear, and for example, I'll give you a very specific thing. In May 26th in the New York Times, there was an article on ADHD. And it was an interview with Harold Koplowitz, who's one of the premier child psychiatrists in the United States today. And he talked about the need to medicate children with ADHD. And he used this thing. He said, if your child had diabetes, would you say no to insulin? Well, of course you wouldn't, because there you have a known biological problem, diabetes, and insulin is indeed a known treatment for that diabetes, because diabetes is caused by a lack of insulin production, or et cetera. But here's the false analogy. A, we don't know the biology of psychiatric disorders, and B, the drug treatments are not normalizing agents. They're actually abnormalizing agents, okay? Because we have a normal function as far as we can tell, and now we're throwing something in and the brain tries to compensate for it, okay? So that's just the paradigm, I think, to understand why, at the very least, you could see why you might want to be cautious with medicating children, because in fact we don't know the biology of what may be behind whatever symptoms they have, and we're not fixing any known biology. Okay, that's the backdrop to this. So now let's look for the outcomes. First, we'll start with ADHD. And the reason we want to start with ADHD is this really is where the medicating of children began. So for example, I was born in 1952. So that means I'm in high school in the late 1960s. I basically didn't know anybody who was medicated. It just wasn't happening at that time. The medicating of children begins happening a little bit in the 1970s with some use of stimulants for hyperactive kids. But it really begins in the 1980s. The DSM identifies attention deficit disorder as a specific disorder in 1980. That's DSM-3. And that's when we really begin on this path of medicating children. But it starts with ADHD, so let's look at the outcomes literature for that. Now, as you know, the way we test drugs is initially as we look at them over a short period of time. Do they reduce some target symptom of the disease? better than placebo over, say, a 6-week period. So what do stimulants do? I mean, first of all, what are the cardinal symptoms of ADHD? It's fidgetiness, finger tapping, not paying attention in school, too much jabbering with other, classroom disturbance, that sort of thing. So do the drugs over the short term quiet the child? Will you see a reduction in social interaction? Yes. They will talk less to their classmates. Will you see a reduction in finger tapping? Yes. Will you see a reduction in all sorts of motor movement? Yes. So in that sense, if you say that the disease symptoms are moving too much, not paying attention, and talking to your classmates, does it reduce all those behaviors? Yes, over the short term. Okay, actually rather effectively. And here's what they say. In 1995, after about 15 years of studies of this, NIMH investigators report 1995, these drugs are highly effective over the short term in, quote, dramatically reducing a range of core ADHD symptoms such as task-irrelevant activity, finger tapping, fidgetiness, fine motor movements, and off-task behavior during direct observation and classroom disturbance. So, what they're saying is the drugs do help the child sit more quietly in his or her seat. Okay, that's what we're really seeing with this, and not be a classroom disturbance. But you see right there, that is not evidence showing that you're helping that child long term. There's nothing in there that tells you about the child socializing better, doing better in classroom, anything like that, years later, benefiting from this treatment. And so in the 1990s, for example, people started looking at this. Do we have evidence that we're doing any long-term benefit to the child? And here's what, say, for the 1994 APA textbook said when they looked at the best evidence they had at this time. Stimulants do not produce lasting improvements in aggressivity, conduct disorder, criminality, education achievement, job functioning, marital relationships, or long-term adjustment. So my point is, 15 years into this revolution, at that point, they had no evidence they're really helping the child long-term. And by the way, if you look at that short-term data, you can even question whether you're helping the child over the short term. So the child becomes less socially engaged with other children. Well, is that necessarily a good thing? You have different perspectives going on there. What we're seeing in that efficacy data is really the perspective of, are they annoying in the classroom? That's really what you're seeing at that point. Anyway, so in mid-1990s, the NIMH said, we have no evidence that we're helping these children long term. So let's mount the first study ever to really study this and see, are we helping children long term? And you can see this is a good thing to do. We want to know that. And this study was called the Multi-Site, Multimodal Treatment Study of Children with ADHD. And as they organized it, they wrote, the long-term efficacy of stimulant medication has not been demonstrated for any domain of child functioning. Just to repeat, at this point, no evidence this is a form of care helping the children long-term. Here are the results. And basically what we had, I'm not going to go into the study design too much, but we had a drug-treated group versus a group treated with behavioral therapy. Okay? And at the end of 14 months, they announced, the NIMH investigators, that the drug-treated group seemed to be doing a little better than the behavioral group. Their core ADHD symptoms, that fidgetiness, etc., they were reduced more. There was also some evidence that maybe they were doing a little better on reading as well. So they said, they declared, aha, we finally have some evidence that there's some long-term benefit. And they wrote, since ADHD is now regarded by most experts as a chronic disorder, ongoing treatment often seems necessary. So there's this sort of sense now we can keep kids on stimulants long-term based on these 14-month results. Now after that, they continued this study, and it was at this point basically a naturalistic study, and they're just going to follow up how all the kids in the study are doing at the end of 2 years, at the end of 3 years. And now kids who have been on medications, if they want, they can go off, or if they've been in behavioral therapy, they can go on. But from this point forward, we're just going to chart how are the kids doing and are they on medication. Okay, and we're going to see if there's any long-term association between medication usage and good long-term benefits. Here's what happened. At the end of 3 years, they reported medication use was a significant marker not of beneficial outcome, but of deterioration. That is, participants using medication in the 14 to 36 month period actually showed increased symptomatology during that interval relative to those not taking medication. And in other words, they had worse core ADHD symptoms, more sort of fidgetiness, that sort of thing, the very things the drugs are supposed to treat. Now, what you see here then is a bit of a paradox, right? They worked over 14 months, but by the time we got into 3 years, even on those core ADHD symptoms, those not on medication, in fact, were doing better. Now, the other thing that was happening at the end of 3 months was that the medicated children weighed less and they were shorter, evidence that the drugs suppress growth. So they continued it for another 3 years. What did they find after 6 years? They said medication use was associated with worse hyperactivity, impulsivity, and oppositional defiant disorder symptoms, and, quote, with greater overall functional impairment. So again, the medication group was not doing as well as the unmedicated group. And one of the lead investigators was a man named William Pelham from Buffalo, and here's what he said. We had thought that children medicated longer would have better outcomes. That didn't happen to be the case. There were no beneficial effects, none. In the short term, medication will help the child behave better. In the long run, it won't. And that information should be made very clear to parents. So at least in this key study done by the NIMH that was designed to see, is this a good thing for children long term? It didn't show up to be good long term. Okay? Now, there's also Oregon State University. They have a group known as the Drug Effectiveness Review Project. It's composed of researchers from 12 different schools. They don't take drug money. They also did a meta-analysis of all the research they could find of ADHD studies. They looked at more than 2,200 studies and that had been done all over the world in the last 25 years. And here's what they concluded. There is, quote, no good quality evidence on the use of drugs to affect outcomes relating to global academic performance, consequences of risky behaviors, social achievements, etc. So when they looked at this big body of research, they're just not finding that they're improving long-term functioning of children. All right? Now, why is this a problem? With any drug, we have risk and we have benefit, right? And we always want a clear benefit over here because we know we're going to have risks. And we need the benefit over here in order to sort of outweigh the risks. Think of a scale. And we just need that benefit. And unfortunately here, at least when you look at long-term, we're just not finding it. At least the when I say we, I mean the NIMH and the Oregon, and again, I'm just a reporter reporting what they found, okay? So what are the risks with ADHD drugs? Well, for example, physical problems. You can get drowsiness, appetite loss, lethargy, insomnia, headaches, motor abnormalities, facial and vocal tics, liver disorders, hypertension, and sudden cardiac deaths. Those are some of the physical problems. Emotional, you'll see with use of stimulants. Depression, apathy, general dullness, mood swings, crying jags, irritability, anxiety, and a sense of hostility toward the world. Psychiatric, you'll see some increase in obsessive compulsive symptoms, mania, paranoia, and psychotic episodes. Those are some of the risks. So we have a lot of risk over here long term, but unfortunately we just don't have at least an observed benefit. Now, there's two things I think that you really, in my opinion, are sort of big long-term worries with stimulants. One is the dopaminergic system is the system that allows us to feel joy in the world. It's our reward system. And there is some animal data. It's not real clear. It has never really been fleshed out. But there's animal data that if you give stimulants to, say, rats, as when they're prepubertal rats, when they grow up to be adults, they just don't seem to be very engaged with the world. They don't seem to be, as the researcher said, it is as if their joyful system has been damaged somewhat, sort of knocked down a bit. So that's one concern. I'm not telling you that's definite or anything like that. It's a concern. And the biology of this would be that since the drugs drive the brain into this sort of low dopaminergic state, you end up with fewer dopamine receptors than normal. That would be a possible biological mechanism as to why stimulants would sort of damage this reward system long term. The other problem you have with stimulants is, one, you do have psychotic episodes. So you'll see a certain percentage of kids that will have an episode of psychosis or mania, and because of that, be diagnosed with bipolar disorder. The other thing, think about this, these are stimulants, Ritalin, etc. Kids start cycling sort of day by day. The stimulants are arousing drugs, so they take them in the morning, and then often they need to take a sedative at night to sort of go to sleep. So they start cycling like up and down. And that cycling as well sort of leads often to a bipolar disorder diagnosis. So somewhere between 10 and 25% of kids on stimulants long term will end up with a bipolar diagnosis today. And the problem with that is now we're taking this fidgety child, right? This kid that's maybe not adjusting well in the classroom, and next thing you know, we've got a diagnosis that's really a serious diagnosis, like they have a lifelong mental condition. And when they move into that bipolar category, they're hit usually with a cocktail of drugs. So you really can see sort of a path to a more serious course here. That's one of the risks. By the way, how many kids today take a stimulant? It's about 5% of all children. Okay, it's more than 3.5 million Americans. I think last I read that American children consume roughly 85 to 90% of the world's stimulants among children. So in other words, it's by and large an American phenomenon, the use of Ritalin. It's happening a little bit in other English countries, Canada, Australia as well, but we are the big users of ADHD medications. So just to put it a little bit in context there, so 5 million, 5%, 1 in every 20, but you don't see the benefit. That's the problem here. Where's that long-term benefit? Where's better doing in school? Where's the better job functioning? We just aren't seeing it. So I actually was in on a debate on a Toronto TV station with a doctor that heads up the mood disorders program at Toronto. We talked about the evidence base, and I said, you just don't have the long-term evidence base. And he sort of admitted it. He said, well, we got this short-term evidence base. But I think many parents would be concerned about the long-term effects. Okay, next with antidepressants. Let's move to antidepressants. Prior to the arrival of Prozac in 1988, what was the thought about childhood mood disorders or childhood moods? Generally, the thought was they cleared up when they became adults. So the sense was, yeah, children are moody, and parents hang on for dear life when they're teenagers because they're going to be extremely moody. But there was a sense that was part of a normal development, including crying jags. And if you've had teenagers, I think you know what we're talking about. Anyway, so that was seen as sort of normal development. So prior to the arrival of Prozac, only about 1 in every 250 children in the United States of school age was on an antidepressant. It was pretty infrequent, pretty rare. Okay, so now let's go forward with the evidence base for antidepressants in children. First of all, before the SSRIs, that's Prozac and selective serotonin reuptake inhibitors, there was a class of antidepressants called tricyclic antidepressants. Those were the earlier generation. They did try them on kids, but they just did not beat placebo in short-term trials. So for example, and this is an 1992 editorial in Journal of Child and Adolescent Psychopharmacology. Very mainstream group, obviously. They write in 1992, there is no escaping the fact that research studies certainly have not supported the efficacy of tricyclic antidepressants in treated depressed adolescents. So we did not see efficacy even over the short term with antidepressants in pediatric populations. In pediatric, I'm really referring to 5 to 17, basically school age. Okay, now we start getting Prozac comes in, and what happens is initially, of course, those are basically marketed to adults, but by the early 90s, and you can even read this in the Wall Street Journal and all, the makers of the SSRIs were looking for new markets. And they started holding conferences about expanding into children. And there was this sense of, we need a bigger market for our drugs, okay? Now, numerous studies then subsequently appeared in the medical literature, but we have a problem to even look at those. And here's the problem. By this time, there was a real partnership that sort of had emerged between the leading psychiatrists at academic medical schools and those who funded the trials. And by partnership, I meant they started working, the guys at the academic medical centers, men and women, psychiatrists, they started serving as consultants on speakers bureaus, as advisors. So they got this flood of money coming from pharmaceutical companies to those doing the trials. And there's no question it corrupted the process. So what do you get in pediatric trials? You get trials where they're biased by design. You get trials where the data that was submitted to the FDA doesn't, we know this now, doesn't square with the data that was published in the medical journals. You get a downplaying of adverse events, and you get, in fact, negative results spun into positive results. And just so you don't think this is me saying that this is what happened, I will read you an editorial from Lancet in 2004. I don't know if you all recognize Lancet. Lancet is one of the premier medical journals in scientific medical history. It goes back to the early 1800s. It's a British journal. It's the equivalent of the Journal of American Medical Association. It's at the very top, the most prestigious medical journal in the UK. They wrote, "The story of research into selective serotonin reuptake inhibitor use in childhood depression is one of confusion, manipulation, and institutional failure." And then they go on to say that the fact that psychiatrists at leading academic schools had participated in this scientific fraud constituted, quote, "an abuse of the trust patients place in their physicians." So what I'm saying is, unfortunately, we just can't go to the published reports in the medical journals to see if they're effective even over the short term. So how do we get a sense of whether they are? Well, what happened was this. Through litigation, through civil lawsuits, it became evident that came out during discovery of those lawsuits, and these lawsuits were initiated because of children who had committed suicide on the drugs, after going on the drugs. It became known that in fact in the trials there was evidence that the drugs markedly increased the risk of suicide in pediatric populations over the short term. So because of that, in 2004 the FDA held a hearing on this risk, and they dropped a bombshell about a larger bombshell. They said there had been 15 pediatric trials of antidepressants in pediatric populations up to date. 12 of the 15 had failed over the short term. In other words, they did not reduce the target symptoms better than placebo in pediatric populations. 12 of 15. They announced that, in fact, they had rejected the applications of 6 companies to market their SSRIs to pediatric populations because, in fact, they weren't medically indicated by this evidence base. The only drug that passed through, that made it past this hurdle for children, was Prozac. Okay, so Prozac got approved for pediatric labeling. However, you have to look at Prozac, how the trials were designed. And what happened was, the way Eli Lilly designed the trials, they had this mechanism that if a child initially was on placebo and started doing well, they washed them out of the trial. Okay? They didn't include them. They kept them away. At the same time, if someone was initially put on drug and didn't do well, they washed that drug non-responder out as well. So the data they collected was on initial drug responders versus placebo non-responders. Nevertheless, at the end, I think it was either 4 or 6 weeks, in rating scales filled out by the parents or the child themselves about their depressive symptoms, there was no difference in the placebo group or the drug-treated group. So it failed on, and that was the primary endpoint in the trial. But the doctors, who frankly probably could tell who was on drugs by the side effects, they gave some benefit to the drug-treated group. So the pediatric labeling of Prozac resulted from that type of trial, and it was the perception of doctors that it was effective in that group, not parents or children. It didn't pass that hurdle. Okay, so that's the short-term benefit or lack of benefit of antidepressants. And again, what happens when British journals, where the influence of pharmaceutical money isn't so pronounced, they reviewed this whole story in 2004, and Lancet said, "The truth is that these drugs, quote, are both ineffective and harmful in children." And by the way, Britain basically banned the use of antidepressants in children except for Prozac. But the British, and because Prozac had made it past that hurdle, but the British Medical Journal then did a review of all this data that they could find, and the British Medical Journal is another very prestigious journal, and they concluded, quote, recommending any antidepressant in pediatric populations as a treatment option, let alone as first-line treatment, would be inappropriate. And the reason it's inappropriate is because it's not beating placebo on the target symptom of depression. Okay, and you can see what it goes back to that risk-benefit analysis. If we're not beating placebo, we're not increasing the odds someone's depression is going to lift, but we have all the risks left. Okay, so what do we see in terms of the risks with antidepressants? Physical, we see insomnia, sexual dysfunction, headaches, gastrointestinal problems, dizziness, tremors, nervousness, muscle cramps, muscle weaknesses, seizures, a severe inner agitation known as akathisia. That's probably partly responsible for the suicide. Psychiatric problems, behavioral problems, panic attacks, anxiety, nervousness, mania, and even psychosis. A lot of risks, actually. The other thing you'll find is, and this is a paper that just came out, they're finding a lot of sort of lasting sexual dysfunction with children teenagers put on antidepressants. And this is coming out of children, say high schoolers, moving on to college, and basically not being very sexually responsive. And there's a woman at the University of Iowa who's written about this. And obviously for someone just moving into adulthood, this is quite the side effect. Unclear as to how common this sort of lasting sexual dysfunction is. And part of the sexual dysfunction is they may be able to orgasm, but just not enjoy it. They just sort of aren't able to mount sort of real intense emotional feelings, that sort of thing. Okay, but that's just one of those worries that is out there, okay? All right. The other big problem with antidepressants is, and you just heard this about how some people move on to have manic episodes, psychotic episodes. Roughly best evidence is that 25% of children put on an antidepressant after about 3 years will move on to a bipolar diagnosis. Their mood swings will actually get worse. After 10 years, the best studies showed, and we won't have a long studies, is 50% did. So again, you have this huge risk with long-term use of moving from antidepressant from depression to a much more lifelong serious disorder. All right? And again, I think you see the problem here. We want to see benefit. We want to see drugs that do knock down depression, that help kids go to college, and help succeedness at school, and we're just not finding that evidence. So now let's look to the big third thing, and that's the bipolar boom. I certainly did not know any bipolar children when I was growing up, and they were not in the medical literature. So for example, bipolar used to be called manic depressive illness. If you look in the pediatric literature and the studies done in the 50s and 60s, can prepubertal children ever suffer from manic depressive illness? And what they would say is no. It's extremely rare. Maybe we'll find a case here or a case there, but we just don't see it in prepubertal children. And you might have it infrequently in 14, 15, 16-year-olds, but very infrequently. It's rare. Okay? So how did we end up today with this big bipolar boom? Because today it's said that 1 out of every 50 American children is bipolar. Okay? 2%. And the bipolar boom has really only happened in the United States. There's nowhere else where they're diagnosing 2% of their children with bipolar illness. So what are the pathways to it? First of all, you need to look at the discovery of it. The place I found it first discovered, because remember before this, 60s and 50s, early 70s, they're saying bipolar illness, manic depressive illness, just doesn't occur in prepubertal children. Then suddenly in 1976, there's a case study. Doctor says, aha, I have 5 patients that are showing signs of this bipolarity from both depression and mania. He gives their case studies and he says, I think I've discovered a new disease. But you've got to look at the case histories. At least 3 of the 5 had been on stimulants before that. Stimulants are antidepressants, okay? So they've been prior exposed to psychiatric drugs. 2 years later, we got the next big case study, 9 children, 7 had been exposed to either an antidepressant or a stimulant before they saw the mania. So my point is, the discovery of bipolar in children arises with the use of stimulants. It coincides, okay? So I think I mentioned that the ADHD pathway, we get 10 to 25% of those treated with a stimulant, put on them long term that will eventually convert to bipolar. That's one pathway, ADHD to bipolar. Second, I think I told about with the antidepressants, 25% after 3 years, maybe 50% after 10 years, okay? So we see those pathways. Now let's go into the 1990s and let's look at our bipolar children. Let's go look, investigators, I got 200 bipolar children. How many of them were initially diagnosed and treated with either stimulant or an antidepressant before they became bipolar? And I'll give you the results. 2003 study, University of Illinois. 62% of bipolar children previously treated with stimulant or SSRI prior to becoming bipolar, okay? Not everybody, but 60%. Dimitri Papoulos, he's the one who wrote The Bipolar Child that really kicked off our sort of societal awareness of this disease. He found in 2004 that 83% of the bipolar children he studied had been initially diagnosed with a different disorder, mostly depression or ADHD, and then converted to bipolar after the drug treatment. Gianni Faida, she runs a mood disorders clinic in New York City, 2004. 84% of the bipolar children in their clinic had been previously exposed to psychiatric drugs prior to the diagnosis. And she wrote, strikingly, in fewer than 10% of the cases was diagnosis of bipolar considered initially. So one pathway to where we're getting some bipolar kids is it in fact kids who've been initially diagnosed with ADHD, initially diagnosed with depression, and basically have been destabilized in some way on those drugs. So we really see these iatrogenic pathways. Doesn't explain everything. We have another pathway basically. You also see in those reviews of bipolar patients is a percentage of kids in fact that have been using illicit drugs. Marijuana, hallucinogens, cocaine, etc. That's another pathway that clearly increases the risk. And then finally is the expanded diagnosis. The expanded diagnosis, there's a famous paper by Joseph Biederman at Massachusetts General Hospital in 1995. And what he sort of redefined what should be seen as bipolar. And he said even sort of a short spurt of, what was it called, extreme irritability could be a sign of bipolar illness in kids. And so he said many of those ADHD kids are in fact comorbid for bipolar. And so this is the moment we see this also diagnostic expansion. And as you know, it's gotten to where they say 2-year-olds can be diagnosed with bipolar, or 3-year-olds or 4-year-olds. Again, this is only happening in the United States, okay? There's no other population that I know of that is diagnosing 5-year-olds with bipolar disorder. It's a phenomenon unique to us, really. Starting again to happen, though, a little bit in Australia, other places as well, where they're starting to use stimulants and antidepressants. Now, the question is, so what happens to the kids that end in this bipolar camp, long term, who never used to be, okay? There didn't used to be any manic. At least then we want to see, well, maybe they get treated and maybe they do quite well long term. And maybe this isn't going to be the tragic story that maybe seemed to be unfolding. Well, what they are, they're usually treated with cocktails that include an antipsychotic, a mood stabilizer, and maybe an antidepressant. So they're not put on one drug, they're put on several drugs. Antipsychotics, long-term, are associated with lethargy, sort of a lack of motivation, physical illness. We're talking about the atypical antipsychotics. These are the newer antipsychotics like Zyprexa. You'll see a higher risk of diabetes, metabolic dysfunction. A lot of the kids will balloon up, a lot of weight gain on the atypical antipsychotics. And it's pretty clear that with long-term use of antipsychotics, you get cognitive decline. You get brain shrinkage. You get brain shrinkage in the frontal lobes in particular. At least in adults, the best study we have seems to be associated with as much as perhaps 1% a year brain shrinkage. Now, there's some thought that that brain shrinkage is also due to the disease. This work is being done by Nancy Andreasen, and she's doing it with schizophrenia patients, and she's seeing brain shrinkage of 1% a year. Now, she's saying part of that brain shrinkage is due to the disease, but it's also dose-related. As she said, the more drug you're given, the more the shrinkage occurs. And that cognitive decline begins to set in after about 5 years. So, at the very least, you'd be worried about putting a kid on an antipsychotic long-term. Symptomatology, what's happening to these kids that are becoming bipolar and treated with the cocktails? Well, they're exhibiting symptoms of a very severe form of bipolar illness. What happens is they become, many of them, the majority become rapid cyclers. They have these mixed states. Rapid cycling is when you move from one pole to the other quite rapidly, like many times a week or many times a year. That, by the way, rapid cycling was never seen even in adults, or very, very infrequently seen in adults prior to the use of antidepressants. Rapid cycling in adults, which A is seen as a predictor of a bad long-term outcome, is really associated with the use of antidepressants in adults. The majority of kids now, it seems, end up rapid cyclers. Many of them end up with mixed states. Mixed states means they can't figure out if they're manic or depressed. They feel the same at both times. I will read this. Barbara Geller, she's one of the experts in bipolar, pediatric bipolar. She says, these children exhibit symptoms similar to the clinical picture reported for severely ill, treatment-resistant adults. They've got a severe form of bipolar illness. Gianna Faida, she was the one I just quoted about, in terms of seeing all the antidepressant exposure. She says, in contrast to a biphasic, episodic, and relatively slow cycling course in some adults with bipolar disorder, pediatric forms usually involved mixed mood states and a subchronic, unstable, and unremitting course. Very severe form of bipolar illness. Researchers at the University of Pittsburgh, quote, functional impairment in pediatric bipolar appears to increase during adolescence regardless of age of onset. The impairment grows as they are on these cocktails. Finally, there was a group called Hayes Incorporated, And they're a Pennsylvania company that does independent evaluations of drugs for HMOs. So HMOs go to these Hayes and says, are these drugs really good? Do we want them on our formularies? Okay, now, so they're not relying on basically psychiatrists who may be getting paid by the drug companies. So they looked at these drug cocktails for pediatric bipolar. And here's what they said. Our findings indicate that at this time, anticonvulsants, that's the mood stabilizers, okay? That's another word for them, and atypical antipsychotics cannot be recommended for children diagnosed with bipolar disorder. They talk about a lack of efficacy, and they note that the side effects from these pharmacological treatments are, quote, alarming. So if we go back to bipolar, didn't used to exist, okay? What do we see? We see these sort of iatrogenic pathways. We see kids diagnosed with ADHD, kids diagnosed with depression, and then finally the expanded diagnostics. And now all of a sudden we have this group, 1 out of every 50 kids. But do we see then subsequently, once they get into that diagnosis, do we see a good outcome? No, we're seeing chronically ill kids. And what can we expect them as adults? Well, what's happening is they're moving right at age 18, many of these children onto the disability rolls, and basically a life as a mental patient. So in my opinion, what the evidence shows is we have a method for taking, in essence, we don't know anything's wrong biologically with these kids. We really have a process that can take a kid that has a bout of depression, or a kid at age 5, 6 that's fidgeting too much and talking too much, and we can, a couple years later, have them diagnosed with pediatric bipolar disorder on multiple drugs, and where we are telling them they're going to be chronically ill for life, and they're going to have metabolic problems, and they're going to have this cognitive decline, and all these side effects. And the final thing is, if you look at what's happening to adults treated with these cocktails that include an atypical antipsychotic, they're now dying early. They're dying 15, 20 years earlier than normal. And as I was doing this book, I asked a very well-known psychiatrist and historian of psychiatry from the UK, David Healy, I said, who, by the way, thinks this pediatric bipolar thing in the United States is just horrific. I said, how long do you think these kids are going to live on these cocktails? He says, well, that's the question we should be studying, but there's a sense is they're going to die very early because they're getting diabetes, they're ballooning up to 300 pounds, so whether they're going to live to 40 to 50, I don't really know. But we're really setting them up for this sort of lifelong illness is what we're doing. So here's my problem with the medicating of kids. We have an accepted value in medicine, and that is that our treatment should be evidence-based, and that the evidence should show benefit, that we're helping people in some ways. What I gave you today, what I've talked about here tonight, is just the evidence compiled not by critics, not by someone who would question this, but by those who are doing it, who in essence who are advocating for it. So talking about the NIMH studies, etc. The antidepressant studies were funded by the pharmaceutical companies. The data I just told you about how they're exhibiting symptoms from those quotes, Barbara Gella, University of Pittsburgh, Gianna Faeda, these are the leading bipolar experts in the country. These are not critics. So what I don't understand is, why are we doing it if we're not finding evidence that we're helping the children long term, say with ADHD? Why are we giving kids antidepressants if the trials failed and they're not medically indicated? That's why the FDA didn't approve them. And why are we not very concerned, not just concerned, why in essence aren't we horrified by the bipolar outcomes, that we have this appearance of these kids now severely ill that we never used to see, and we only see them once we sort of adopted this medication paradigm, and we don't see good outcomes for them. That's a story, in my opinion, of harm done on a grand, grand scale. And finally, I want to revert back to one thing. Again, the public has been led to believe, Harold Klopowitz said, why would you not give your child insulin for diabetes? Well, I agree. If your child has diabetes, you should give them insulin. But we don't know the biology of any of these things. That ADHD kid does not have a known biological problem. I quoted that to you. We don't know what it is. The depressed child, We don't know if they have any known biological problem, okay? So we are taking children that, as far as I can tell, are physically healthy, and we're putting them down this other path. And that's one of the things I write in this book. And last bit of data, 1987, there were 16,200 children in America on government disability due to a mental illness. Okay, and then we started the medicating. Today there are 600,000. So a 35-fold increase. There's about 100,000 children per year who are going on disability due to mental disorders. And at age 18 now, you're seeing this big bulge. Those kids are going right on to the adult roles, and you can expect them to be on those roles for life. And the final thing is, if you look at the adult disability roles in the past, they were largely populated by psychotic disorders, schizophrenia or schizoaffective disorder. There weren't many mood disorders. If you look at the young population on the government and the adult disability roles, the 18 to 26, it's being populated by children who are, quote, depressed or have bipolar disorder, mood disorders. This is a new group. We didn't see them. And it rises in conjunction with this rise of medications. So I think we have time for a few questions, right? Anyway, thanks very much.